everyone, and thanks for joining this webinar. We are also delighted to have Dr. Richard Leff and Dr. Harsimrat Singh to talk about cognitive load assessment in surgeons. And personally, that's what excites me about fNIRs, which is its real-life applications. Daniel and Harsimrat work with surgeons in the operating theater, and fNIRs is very suitable, I think, for such real-life research. It can be mobile, it's very safe, and due to its optical nature, does not interfere with any other modalities. Harsimrat will talk later how they are using fNIRs in combination with TDCS, for example. Now, when working in unrestricted naturalistic environments where the participants are doing real-life tasks, movement is expected, and movement might cause artifacts. Then there's change in physiology. During certain tasks, there might be an increase in heart rate, respiration, or blood pressure. So it kind of becomes important that we address these covariates that lead to experimental variance. And we at NIRx have been doing that for the last 20 years. And we have been playing our small part in providing solutions that are optimized towards that end, whether it's whole head mobile solutions, dedicated short channels to capture and correct for physiological confounds, or motion sensors, for example, to correct for movement artifacts. We try our best to give you the tools to do the best research. And with that, of course, there's a team behind that. There's a team behind this webinar. My name is Mahipal. I'm a scientific consultant with the NIRx Berlin team. Alongside with me is Maria Delia, also scientific consultant, actually just finishing her PhD in fNIRs, and Dr. Milene Henry, who is, let's say, the brain behind all these webinars. About our speakers, I'm very excited to introduce Dr. Daniel Richard Leff. Daniel is a reader in surgery working at Imperial College of London. He did his PhD also from Imperial College of London. He was working with Professor Ara Darcy and Professor Guang Zhongyang. Daniel works with the Hamlin Center, focusing on neuroergonomics and perception. And he has published, very impressively, 100 scientific papers in peer-reviewed journals on the subject relating to application of surgical technologies, assessment of cortical brain function, and surgical oncology. Of course, a profile like this deserves all the accolades, and Daniel has won numerous number of prizes. Our next speaker is Dr. Harsimrat Singh. Harsimrat is a researcher at the Neuroergonomics and Perception Lab. Did his PhD at Intelligent Systems Lab at University of Warwick. He was working on EEG-based BCI approaches for detecting awareness in human disorders of consciousness. So kind of related to what he's going to talk about today. At ICL, he leads the analytics on cutting-edge applications such as cognitive load assessment in surgeons and gaze patterns in surgical operations to understand the surgical skill acquisition, performance under pressure, and expertise effect. So we must thank Harsimrat for doing this brilliant work, for enabling people who save lives to do their best job. He has published in very high impact journals. And together with Dr. Daniel Leff, Harsimrat is working towards the concept of mind-operated operation room to improve surgeons' reliability and empower patient safety. There are some considerations to this webinar. Of course, we want to hear from you, but for this webinar, you are muted. Your questions are, of course, welcomed at any time. Please go to the webinar panel and write your questions there. We will discuss the question towards the end of the webinar.
Hello.
Webinars are being recorded. Oh, I see someone. Okay. I will just continue and then introduce our speakers. This content will be available on our website in the upcoming days. You can check nirx.net/webinars.
Yeah. So
Okay, I think one of our
I've gone
speakers
to the GoToMeeting. I've ticked the
troubleshooting.
icon.
Right, let's wait a couple of seconds. Right, okay. If you have any further questions after the webinar, please do not hesitate to write to us at consulting@NIRx.net. With that, I would like to invite Dr. Harsimrat Singh to talk about his research.
Hello?
Great. So can you see my screen?
Not yet, Harsimrat. Yes, now I can. Perfect.
And you can hear me as well. Yeah.
Do you want me to go to the
I
other
can
meeting?
hear you. I can see you as well.
Okay.
I'll come
great.
off and
Just one moment, Harsimrat. If I may ask Made to mute Daniel, perhaps. Okay. Okay.
Go on.
This should work. Thanks a lot, Harsimrat. Floor is yours.
Great. I'm excited to be talking about something that I've been working on since last 5 years now. And the talk actually is I pick up a strand from Dan's talk, which was supposed to be prior to this talk. So, but I'm gonna give you a bit of background on this. So basically, we are looking at cognitive monitoring of surgeons with regards to skills acquisition and improving their skills as well. Looking at performance under stress and under time pressure, fatigue, things like that. And the point is to make smart people even more smarter. So my talk is focused at actually augmenting technical performance in surgeons. So I pick up from our recent paper in JAMA Surgery in 2019, where we look at the hemodynamic oxygenation for people who, for surgeons, actually who deteriorate under time pressure. So people who are resilient to stress versus people who choke under stress. And so this paper was focused at the deterioration from a self-paced task operation to a time-pressured task operation. And we are talking about surgical stress. So what we see in this is that the HBO overlay plots that the copers are resilient to stress and show a better engagement of their prefrontal cortex, and depicted by higher activation in red and orange. And the chokers, or the people who are more sensitive to stress, have their prefrontal deactivation. And this is irrespective of their expertise. So around 50% of junior residents are in the stress resilient group, and 25% of the senior residents actually are in the stress sensitive group. So what we see here is that when you are operating under stress, some people deteriorate more than others, which is shown from this graph. For example, you look at subject number 16. The performance score was around 0.58 when he was doing the operation in his own time, but that actually reduced to 0.21 when he was operating under time pressure. And surgeons are often have to make these decisions of doing doing the operation quicker than to stop a bleed or something. And you see this subject number 33 actually improves only a fraction under time pressure, although he was a senior surgeon. So the blue are senior surgeons, the red are juniors, and the orange are intermediates. So we wanted to look at this a bit further. So we conducted a study on actually layering these tasks with more cognitive tasks. So we had fNIRS recording on the prefrontal cortex, and then we had those two tasks of actually doing laparoscopic surgery in their own time under self-paced condition, and and under time pressure. But on the top of that, we had another task where we were asking them to make medical decisions while they were doing this surgery in their own time and while they were doing under time pressure. And then we were measuring their task progression, their error scores, the leak volume, and the knot tensile strength of the knots. So we wanted to look at the brain connectomes and the brain connectivity aspect of this this task effect and the condition effect. So what we see in this black plots, we've got lots of connections in the brain. In the juniors, the covariations are much lower than the seniors. And the brain networks under bimanual tasks in senior residents are more resilient to time pressure compared to junior surgeons. So we wanted to look at whether we can quantify this. And what we used was a parameter called small world index, which shows a significant difference between conditions, which are the MSP, MTP, or MCSP and MCTP, and also the expertise, which is juniors versus intermediates and seniors. So some of them are significantly different. So this is a very interesting result, and wanted to see if this can actually tell us and classify the brain data and tell us which condition was the surgeon operating under. So if he was doing a motor task in his own time, or was he doing it under mental pressure? So basically, we're looking at surrogate marker of mental state of a surgeon. So that's what we did. We took the data and looked at the classification features of small world index and efficiency, and color-coded them to experimental condition, which reveals a profound separation across conditions in the plot A. And similarly, for the expertise in plot B. So across experimental conditions, the overall accuracy of the classifier is 95%. So actually we can classify the data from the brain up to 95% and make a correct decision on which condition was the surgeon operating under. And for expertise, it's 76% based on a 10-fold classification. So this was a big leap forward. So what we have is neuroimaging, which is the fNIRS, and then we know the role of prefrontal cortex activation, that it's very much involved in learning of a surgical task, and there's activation in early stages of learning. Also, what we know is that there are several stress scenarios that surgeons often have to operate under, and there's greater engagement of prefrontal cortex activation in stress resilience. So can we augment the prefrontal cortex activity? And if we did that, then what we would have is an outcome in terms of improved learning of surgical tasks and better performance under stress. So what can be used? So we found this technique called transcranial direct current stimulation. It sounds a bit scary, but you're going to pass current through the brain. But I'll show you it's not that scary. So what we wanted to see was whether we can augment surgical training. And I'm going to talk about three main aspects of that: the impact of prefrontal TDCS on basic surgical skills, on complex, minimally invasive surgical skills. And I'll show you two studies from this strand, where we're talking about a robotic environment and robotics tutoring, as well as on the simulator. And then actually we want to know about the neural correlates. What are the neurophysiological mechanisms when you actually augment a surgeon's brain through TDCS? So it's not ECT. It doesn't look like what's shown in the video, but in fact, it is something like this, where the participant is actually able to talk, is comfortable, he's normal, the behavior doesn't change, and it's quite safe to do. What you're talking about is 2 milliamperes of current being passed from the brain. That is actually very, very small amount. So you have a simulated device, and the current is passed from an electrode, on positive electrode, to the negative electrode on the scalp. So it's totally non-invasive. So it's quite safe. There was a study of around 30,000 sessions or something by Mayram Bixson, who's a pioneer in the area from NYC, and they couldn't find even 1% of serious adverse events in those 30,000 sessions. They did find 15% of discomfort, for example, redness of skin, etc. And then they found some irritation in 39%, which is not much, to be honest. So what's the point of doing this? The first time I mooted this idea to my team of surgeons, they were like, this guy is going to electrocute me, and not really. So what's the point is, as you can see from this graph, this was a study in New England Journal of Medicine. The rationale behind this research is that there's ample evidence to suggest that the patient outcome depends on the level of a surgeon's skill set. So we're looking from the patient safety point of view. So the study demonstrated that the increased rates of post-operative complication in surgeons seemed to be of lower skills, as illustrated by these blue graphs. And for example, in cancer, the worst outcomes associated with lower skilled surgeons, as you can see in the operative duration and blood loss and surgical morbidity. So the evidence suggests that we need to do more to improve the development of surgical skills among surgeons, as this could have a profound effect on patient outcome. So there are several challenges in surgical training, and there are several other studies which demonstrate that surgical training is lacking. For example, between 2016 and 17, it was revealed that the 0.3% of the surgical training posts in UK met national surgical guidelines. That's pretty low. Furthermore, the other study of nearly 700 surgical residents, 38% felt that their residency program did not sufficiently prepare them for practicing general surgery. And finally, this was also corroborated by evidence from 91 surgical directors who felt that, for example, over half of trainees cannot laparoscopically suture. So altogether, this suggests that the surgical training does not sufficiently develop the surgical skills of trainees, and that this is detrimental to patient safety. So what is expected? The studies have previously described the discrepancies. But there's a surgical level proficiency that you have to achieve with variable time to desired competency levels. So the blue indicates ideally trainees would achieve the desired competency level with a defined period of surgical training. The red indicates a slower learning, achieving competency, but only after becoming a consultant, at which point actually such levels would be expected from the start. And the orange shows slower learning, not yet achieving competency levels. So what can be done to expedite reaching proficiency benchmark quicker? So a number of extrinsic factors have been developed to reduce the learning curve of a surgical task and therefore contribute to improved surgical skill despite reduced investment of training time. And green plot kind of suggests a surgical learning curve in the absence of an intervention, therefore requiring a greater amount of training to achieve that proficiency benchmark. The blue, which is coming up now, actually shows the long trajectory of the longitudinal skill development following the introduction of an intervention, which reduces the learning curve. The proficiency benchmark is acquired earlier, and competency can therefore be achieved and maintained during surgical training time period prior to consultancy post at the takeout. So could TDCS be used here to expedite competency and improve surgical training? So the first study I'm going to look is the impact of prefrontal TDCS on basic surgical skills. So what we did was we recruited 40 medical students to assess whether stimulating their prefrontal cortex could actually improve their surgical skills. So we simulated their prefrontal cortex with a bifrontal montage of 2 milliamperes. We wanted them to have a certain level of skill before we did the stimulation. So we trained them for 50 minutes using rope training and then 10 minutes using actual sutures. And then after that, we did task evaluation where we had pre-TDCS block, a rest period, and then online TDCS where they were actually doing the task, and the TDCS was either TDCS or shams simulation was being administered, and then the rest and the post TDCS. So this paper has been recently accepted, actually last week, in brain stimulation. We're quite chuffed about it. So why do we use this 2 milliamperes? Numerous studies have demonstrated enhanced cognitive behavioral measures using this montage. Recently, several works by Michael Nisch's group suggest the role of current intensity in neuronal excitability with a 2 milliampere delivering a net increase in excitability under both electrodes. And recent work by our collaborator, Professor Adam Woods in University of Florida, has also facilitated functional connectivity under the cathode with a bifrontal montage. So this shows a current distribution. So what we found was quite encouraging, actually. There was a significant improvement in performance scores with active stimulation and a non-significant decline in sham. So basically, significantly higher performance scores following stimulation with as compared to sham. So that's really intriguing. Delving more into this data, we were looking at skill sets. So individuals with low skill and higher skill. And what we found was that the both active subgroups, which means the TDCS with low skill and TDCS with high skill, actually improve their performance score, something that was not observed in the sham groups. The post-simulation scores were significantly higher in both low and high skilled individuals when compared to sham. And if we look at individual performances, within these subgroups, there was a clear improvement in the TDCS group, with all of the lower skill performers improving, and 80% of the higher skill performers, the light yellow ones, improving too. So encouragingly, this in the sham group did not demonstrate this habituation, as only 40% improved overall. So this study provided a strong basis to suggest that prefrontal TDCS could improve surgical skills. So we wanted to look at more complex and minimally invasive surgical skills, for example, laparoscopic skills, and we employed a simulator for this. Similar to the first study, we recruited 40 medical students, and they were doing peg transfer tasks or pattern cutting tasks, which are surgical tasks for pre-TDCS or sham, pre-stimulation, during stimulation, and post-stimulation. So active TDCS or sham TDCS were the two randomized the groups, and actually the investigators were blinded to which group that individual was actually doing the experiment, and the analysis of the performance scores were also done by an individual who was blinded, similar to the first study. So what we found was that there was improvement in both active and sham groups for peg transfer, and only in the sham group for the pattern cutting. However, the active group were 5% more likely to complete the peg transfer and 7.5% more likely to complete pattern cutting tasks, respectively, which is perhaps reflected in the subjective reduction in perceived time pressure. This is a finding that was also present in the previous study. So we wanted to look at the robotic suturing, which is another platform quite often being used by the bariatric surgeons. And so we recruited 15 surgical registrars in a crossover study, again with a pre, during, and post block of stimulation. And they carried out robotic suturing. So they did that, and they came next week to do the other stimulation that they had not done previously. And then their performance was measured using progression scores, leak volume test, not tensile strength, and error scores. So what was the impact was that TDCS had a significant improvement in error scores from pre to post. And not tensile strength was significantly higher after active, was actually significantly improved after active stimulation compared to sham. So the comparisons of distributions here and not median values. So we found that TDCS can actually improve performance and actually help you learn a surgical skill better. But we want to know what's going on in the brain. So we want to understand neurophysiological mechanisms. We want to evaluate immediate and subsequent effects of TDCS and correlate performance improvement with neurological change, or differentiate between those who TDCS has improved to a trained novice level or versus those who have improved to an expert level. So what we did was we had a NIRx system, and we wanted to do a combined concomitant TDCS and fNIRS, for which we devised a montage and placed the electrodes on F3 and F4, F3 being an anode. So the experimental design was actually the same as the first knot tying study, but it was just that fNIRS was added to this block, to each block actually. So we had 9 hand knots, 15 minutes doing pre-TDCS after the 30 minutes of training, obviously. So we wanted them to have a consistent level of scale before they were actually put under stimulation. And then a post-TDCS block, again with 9 hand knots. So continuously there was fNIRS being monitored during, pre, and post. So what we found was a typical response to a functional task. So there's increase in HbO2 and decrease in HHP in most channels in pre-condition. And in online, there was significantly more significant differences between increase in HbO2 and decrease in HHP, and similarly, few channels for the post as well, giving a typical response to a functional task. So what you find here is this is HbO data from all participants. Each gray panel represents each individual channel. Within each gray panel, there are pairs of box plots for the 3 conditions: pre, during, and post stimulation. So what you see is that there is a significant change from the baseline to the task period, as shown by those yellow dot plots, and from during as well in most channels, and then in the post stage as well. So some of these were significant as well. So there was a overall pattern was that of a typical activation response with a rise in HbO during the task, with many being statistically significant as well. So here is delta HbO2, which is basically task HbO minus the baseline, and comparison of each channel for pre, post, and during conditions. And you can see that the delta HbO data, the magnitude of change between the baseline and the task is being shown. And these were significant from during to post, as well as from pre to post, and from pre to during as well in some. So let me introduce a concept of neural efficiency in so the neural efficiency hypothesis of intelligence suggests a more efficient use of cortex in brighter as compared to less intelligent individuals. So Dunst et al. Said the similar thing, that was a phenomenon that brighter individuals show lower brain activation than less bright individuals. So neural efficiency can also be related to performance. For example, in elite athletes, they achieved superior behavioral performance with minimal neural energy consumption. So what we see is an evidence of neural efficiency. For example, in this channel 10, what you can observe is that the pre curve time course is actually higher than the post. So perhaps the activation is lower in post. That means the brain sources are allocating their energies in a more optimized way, in a more efficient way. This is also seen from the reduction in magnitude of HBO change, indicating neural efficiency. As you can see, that there is decrease in delta HBO2 in channels. In pre, some of the channels are in the pre, but then as the experiment goes on, this is actually even more pronounced when it comes to post. So the differences between pre and post, there's a lot of decrease in HBO magnitude. So I want to touch on an ethical perspective of TDCS, and we've written a paper. My colleague Ronak Patel has written one for British Journal of Surgery, Neuroenhancement in Surgeons, the Benefits, Risk, and Ethical Dilemmas. So we conducted a qualitative study to actually further delve into this of 191 patients and 168 medical personnel. So what we see is that it is a lot of patients agree to the fact that if TDCS was shown to improve surgical performance, it would be beneficial in surgeons, all the surgeons basically. So even below average, average, or above average. So they agreed to this fact. And it is okay to improve a surgeon's ability in this way. Patients thought that that was all right. And it is immoral to improve a surgeon's ability in this way. And surgeons thought, no, it's not immoral. So that's good. If shown to be beneficial, the TDCS could be a requirement for all surgeons to use it. So in that journal, opinion was that it shouldn't be made mandatory or compulsory. So why not do it? Let's do it. And it's shown to be shown to improve. There's a lot more work going on in our lab. With our clinical research fellow Ronak Patel and the team, where we're going to look at retention of skills and the BCI aspect of surgical skills as acquisition as well, taking us closer to mind-operated operating theatre. Thank you very much. I have my colleagues whom I enjoy working with. I'm very happy to answer any questions.
That was fascinating, Harsimrat. I need to go back and read all of your papers, and perhaps I should get a TDCS device myself. Seems to work really well. Just a reminder for our users, we have, Harsimrat, a lot of questions, of course. We have a lot of people joining. There's a lot of thanks and kudos to you. That is really good. Another reminder for users who have joined late, please feel free to write your questions in the questions box in the GoToWebinar panel. Dr. Harsimrat's talk will be recorded and will be uploaded on our website. The second part of this talk is with Dr. Daniel Leff, and he will be joining us in a couple of seconds. Seems he's there.
Are you able to hear me?
Yes, Daniel.
Fantastic. I don't know if you can see me, but at least you can hear me, which is good.
I can hear and I can see a beautiful, colorful screen as well.
Okay. Hopefully, let me just see. Hopefully you can see the slides. Can you see the slides now?
I can see the slides as well.
Excellent. All right. Well, we've gone in slightly, as Harsimrat says, we've gone in slightly reverse order here, but that was just slightly to do with a technical glitch. But hopefully I can fill in some of the blanks from where this all started. Let me just.
I see you as well now, so we are.
Fantastic. Okay, great. So, so my intention here is really just to give you a bit of a, just bear with me because this screen keeps popping up, just get rid of that. So, is to, as I say, try and fill in some of the blanks in terms of where this really started in our lab, and lead you right up to the point where Harsimrat picked it up. So, when I joined the department, which was actually back in the early 2000s, we really had a better understanding at that point from a lot of the studies that have been done regarding the anatomy of a surgeon, if you will, the aspects of surgery, of surgical performance that was important. We were certainly starting to get a better understanding of dexterity, and there had been a lot of work done on communication, perception, but very little at that stage on cognition. It's true to say that around the same time, there was a lot of an emphasis on the technical craft, the technical skill of surgery, and Harsimrat, as Harsimrat alluded to, we're seeing more studies coming out subsequently that really do confirm that surgeons' technical ability relates to their patient's outcome. A lot of studies now really evaluating that using video-based ratings of performance in real surgery. In addition, at that time, we had really understood that a lot of the way that had historically been used to assess surgeons was very subjective, and we needed to move to more objective systems. We also had pressures coming in at that time. It's interesting to think about it now with the whole Brexit situation, but we had the European Working Time Directive, which really restricted and diluted the amount of exposure that surgeons had to cases. So we had to find smarter ways to train and assess. We also had a situation where we were developing, and my colleagues before me were developing simulations that were far more realistic, even using silicon-based models, as you can see here, such as a beating heart phantom, where you could really recreate the skill of, for example, closing a wound, as you can see on the screen, on a beating heart phantom, for example. We also had, at that time, really started to get to grips with VR, virtual reality surgical simulation, with inbuilt metrics of performance, time, efficiency, diathermy, so that's electrocautery use, and end product assessment, as you saw on the screen just before, against checklists using, for example, simulated surgical skill, and dexterity measures using motion analysis, which you can see on the right of the screen. In addition, just prior to my arrival in the department, colleagues were working on eye tracking technology and really alluding to differences in visual gaze behavior between expert and novice surgeons. And of course, that was really just a window into the brain, and so it made sense to take the next leap forward to evaluating brain function in surgeons. I think it's true to say that at that time, there were some very interesting findings that were coming out from those studies looking at dexterity that really couldn't be explained by those tools at the time. So as you can see on the left, the number of hand movements, for example, to perform a surgical skill against the levels of increasing surgical expertise. And of course, you see there's a number of hand movements come down the more experienced you get. But clearly there were some more junior surgeons performing almost as well as senior surgeons despite far limited exposure. There's also quite a range of performance within each experience group that again couldn't really be explained by those tools. They weren't designed to tease that out. And in addition, longitudinal studies, and I think as Harsimrat alluded to earlier, really were telling us that the way people learn was clearly not uniform. There was a lot of individual subject or individual surgeon variability in learning curves over time. In addition, we had a lot of studies have been done on IQ, more small dexterity tests that were not related to surgery to try and see if they could predict your surgical performance, and mental rotation tests, for example, for laparoscopic surgery. And in truth, very little, you won't be surprised to hear perhaps, that very little of that correlated with your actual technical surgical capability. So we couldn't really use these aptitude tests so well. And that led us really down the line of, well, what about actually assessing or getting some glimpse as to what's actually happening in the brain of the surgeon. And that really led us down the road towards the prefrontal cortex. Of course, there were lots of areas on the cortex, as you can see on the video, that we could have focused on. But what was interesting at that time was a lot of studies coming out on skills acquisition that were telling us that the prefrontal cortex was an area of attention to action. It was an area that was important for establishing new spatio-temporal relationships between the hands. It was an area that was nearby other regions looking at error detection and monitoring of performance, and so it might be recruited as a result of that early in your skill performance. And the theory that it actually acts as a scaffold to support those novel demands, and then that scaffold falls away as you become more experienced. In addition, of course, we infer from patient studies that those with prefrontal lesions really struggled to learn new tasks, and so it made sense that the prefrontal cortex was important for novel task acquisition. It was also interesting, well, certainly to me at the time, that there were studies that had been shown, that expansion, for example, in M1, Avni Carney's work, for a trained sequence, repeated practice of a trained sequence led to expansion of M1 activations, as you can see on the left of the screen. In addition, there were papers that were summarizing the changes that were occurring in learning studies as redistribution effects. So as you can see on the screen, similar areas at the beginning of practice, pre-training to post-practice, post-training, just the amount of allocation of activation is different in that redistribution of activation foci. And similarly, reorganization, where new areas are cropping up at the end of training that weren't present at the beginning of training, suggests a shift in the cognitive plan. I was also fascinated at that time by studies that had been done outside of the world of medicine. So thinking about the world of music, for example, where there were a number of studies at that time that were publishing findings that would suggest that experts use, as Harsimrat alluded to, far more refined resources. They may be recruiting similar areas as seen on the screen, a typical expert E against a novice N in the study by Krings and colleagues, demonstrating that experts really can control many more degrees of freedom through finer resources. And even more fascinating, and again it was alluded to in the previous talk, this concept that the brain of learners that are faster learners might shift more rapidly than those that struggle to learn tasks was also very relevant for surgical training. And the study by Joe Tracy and colleagues on sailing knots, teaching novices to learn those sailing knots, it was fascinating to see that those that struggled to learn repetitively fired the prefrontal cortex. And that really led us down, unsurprisingly, a prefrontal hypothesis, essentially, that we published, where we postulate that novices would use the prefrontal cortex to a greater extent, that area would be spatially broader than the expert surgeon, and that the networks would change and adapt to become more efficient, as Harsimrat mentions, over time. And of course, we had the challenge of how on earth would we evaluate surgeons. Subsequently, colleagues have done studies in the MRI magnet, but you can see that this is not particularly comfortable, number one, and number two, we don't really learn surgical techniques in this way, and so one wonders what the ecological validity, if you like, of such an experiment is. And that really led us down the path of functional near-infrared spectroscopy. And I respect the fact that many of you listening may be very experienced users, but we may have those on the line that really are very new to fNIRS. So, you know, this concept that you can shine near-infrared light, you know, through the skull, it will penetrate the skull, be absorbed and scattered on the cortical surface, and then be detected back at an array of fixed detection points, and that you could then infer changes in the hemodynamic, the local hemodynamic changes, which themselves are a reflection of the amount of cerebral work, was really fascinating, because clearly, as you can see, you could be, it was a real revelation at that point to me, certainly, because you could be up and about, mobile, you could really assess somebody in a slightly more real world setting. And then I was introduced to Professor Delpy and Professor Elwell, and we conducted the first set of studies in their laboratory at UCL, And although this looks like I'm being tortured, actually it does illustrate some of the very important technical aspects of a good fNIRS experiment. You need to secure the optodes onto the head so that you don't get that shift in the optodes that causes motion artifact. The possibility or the need to better isolate the task, having the subject comfortable, ideally having some kind of assessment of their behavioral performance if you're doing a motor experiment. That's either through some kind of video analysis, or as you can see here, using sensors on the back of the hand to get behavioral correlates, and having the room dimly lit so you don't get that interference of ambient light. What was also interesting was that despite this really fascinating technology that could really unlock applications in more real-world settings, actually fNIRS hadn't really been used, I think it's fair to say, in that way so much. We were really looking at motor tasks that were quite simple in the mid-90s, leading up to more complex things such as apple peeling, pursuit rotor tasks. But surgical skills was, I think it's true to say, one of the more complex end of the spectrum that we felt was really going to hopefully unlock the potential of fNIRS for real-world environments. And then we invested in at that time, of course, Harsimrat's presented subsequently on NIRx data, but at the time that I'm speaking about, going back a number of years, we used the Hitachi ETG 4000 system. You can see here an array of 3x3 optode array with a surgeon about to have everything deployed onto their head through those thermoplastic holders. And you got a glimpse there that what we're really trying to do is create, where possible, the highest fidelity experience for the surgeon. So to have them scrubbed with a surgical gown to try and, because we know from other studies that the more the subject buys into that, even if it's in a simulated setting, the more likely you are to get more realistic measurements. Of course, we needed to have some sense of where the optos are positioned. fNIRS in itself doesn't give you any anatomical information, as many of you will know. So we use 1010 or 1020 system reference coordinates. Here you see an example of our subject sitting down as a graphic illustration. You see the labeled red emitters, the detectors, and then the numbered channels in between, 12 on the right and 12 on the left, prefrontal, with the labeled coordinate positions on the diagram there. This video will probably also illustrate the digitization process, which we can then overlay those positions onto an MRI atlas to get a better sense of where the channels are positioned. And I think it's true to say that that's quite helpful to do if you can, as much as these technologies, in my experience, are not necessarily the easiest or most reliable to use. I think it's true to say. But I think if you're able to provide some evidence of where are your measurements from, and what is the degree of between subject kind of variability in that, I think is important, and especially if you're doing repeated measures longitudinally, to give confidence that the measurements have come from approximately the right area every time. What's the typical response that we expect from fNIRS? Well, it's illustrated here on the screen. So the rest period in white, the stimulation period in yellow. We expect to see that rise in oxygenated and total hemoglobin. Unsurprising, you're trying to get nutrients and oxygen to the area of the brain that's working. And then deoxyhemoglobin is washed out of that area faster than it can be produced, and hence you see a lower amplitude and slower decline in the deoxyhemoglobin response. And as Harsimrat alluded to, in terms of our basic analytical strategy, without talking about more complex analytical techniques that Harsimrat went into briefly at the start of his talk, essentially what we're looking at is a time course of the response. We typically ask the question, did oxyhemoglobin go up from rest? Did deoxyhemoglobin go down from rest significantly? And that can provide you with what we refer to, certainly internally, as an activation matrix, a matrix of where your significant rises and falls have been. And depending upon who you are, which lab you work in, you can accept either a looser threshold for activation or a hard threshold, which would be only accepting channels where oxyhemoglobin has risen significantly and deoxyhemoglobin had dropped significantly. When we compare across subjects and across conditions, that approach isn't particularly helpful, because of course you can only then qualitatively compare those activation maps between different expertise groups, for example. Hence the delta HB analysis that Harsimrat alluded to, where we subtract the task hemoglobin from the rest hemoglobin, and then we have a like-for-like fair comparison across expertise and conditions. We also have applied random effect analysis to account for clustering in repeated measures designs. So one of the first, I'll take you through a few of the earlier studies. So one of the first things we looked at was surgical knot tying. This is open surgical knot tying as illustrated on the screen. When you see it performed in its entirety, it looks like a relatively straightforward skill. But actually, as you can see here on the right of the screen, as you break it down into its various constituent components, actually, at that time, it reflected one of the more complex motor skills studied with fNIRs. We performed, or I, in my early PhD, performed a study looking at a cross-sectional group of consultants, trainees, and novices after limited training on open surgical knot tying. And we evaluated them using dexterity measures, such as the Imperial College Surgical Assessment Device that converts those spatial data into meaningful dexterity measures, such as the time, the total path length in green, and the total number of movements. And you can see, whilst for a very basic task that trainees can automate reasonably swiftly, you can see that there's no difference between the consultants and the trainees, but quite substantial differences after only early exposure in the novice group. I think, and I think Harsimrat and myself both agree that we tell the PhD students to get to grips with the hemodynamic time course before we run any analysis, because really it's like this is really where you read the data. I mean, is there really a response there or not? Hopefully you can see that in this experiment that there are some areas and some channels where you can see quite marked oxyhemoglobin rises. With an image or a series of images, maybe talking 1,000 words, here you see the expert performance on the top left and the novice performance on the bottom left. You can sort of see the difference in both the speed and efficiency, I guess, of the hand motion, plus that longer path length, as you can see in the novice. And we are showing you on the right of the screen the oxyhemoglobin response as a video topogram, if you like, overlaid onto the MRI image. And you can see that there's quite a substantial difference there in the amount of prefrontal hemodynamic response in the novice. Very interested to see, is that something that is just an effect of the speed with which the expert is performing? So we took various cuts through the data, and you can see that it really doesn't matter at whatever stage you're in, there's more of a response in the novice versus the expert. Again, then going back down to the data to pluck out representative channels. Here you see in bold red the oxygenation response of novice, dotted red the consultant. Again, you can make out this very pronounced hemodynamic response during the task in multiple channels. Of course, you will then want to apply some statistical analysis to that, and the pattern that we're really looking for is that rise in oxygenation hemoglobin coupled to that drop in deoxygenated hemoglobin. So now we're talking about a pretty hard threshold for activation. Where is it located? Predominantly in this experiment in the left prefrontal cortex of novice subjects. Not happy with one way of evaluating the data. We've often gone on and evaluated multiple analytical techniques to give ourselves, if you like, that reassurance of really what are we looking at? Are we really looking at something that's reliable in terms of the trend? Here you see another way of evaluating that response would be to look for where the greatest inverse correlation, the greatest rise in oxy coupled to the greatest drop in deoxy should give you this inverse correlation analysis. And you see here the greatest response, the greatest inverse correlation between oxy and deoxy is in the left prefrontal cortex of novices. It's convenient in many ways to look at or it would be very convenient to look in a single map at the data set. The problem with fNIRS data, as I'm sure those on the line that have got experience of it will attest, it's high dimensional data, it's complex data. You've got many channels, many hemoglobin species, often many subjects. Here, the way we approach that with such a large number of subjects and channels was to try to reduce the dimensionality. And here we use a non-linear dimensionality technique. We knew that this data set was non-linear. And as you can see, much like the Swiss roll manifold, that essentially it doesn't make sense to use a straight path distance to describe that high dimensional space, and fISOMAP essentially respects that non-linearity of the high dimensional data set. What you can see as this video is essentially the mapping of the data set. So the consultants, now you're looking at in individual point is the entire distribution of the oxy and deoxy response. Now we're mapping the response of the registrars, and you'll see the much more diverse and dispersed response of the novice subjects. But what's fascinating is if we then sample across that low dimensional embedding, if you will, you see that the areas of the greatest oxy rise, deoxy drop. So now we're going back to the original signal as we sample across this manifold. You see that the greatest response is in the upper outer quadrant of this embedding, the area where predominantly the novice subjects are located. The other advantage of this approach is it allows you to use something called Earth movers distance, where you conceptually imagine morphing the distribution of one group onto another, and that's work, and the function of work is distance and hemoglobin. And you see that you have to work not very hard at all to morph the distribution of registrars and consultants, those brains, onto one another, and have to work much harder to morph the novice subjects to the registrars and the consultants, thus saying that there's something very different about that distribution of brain response in the novices. The next step was clearly to take a second group of novice subjects and then train them. So we trained them briefly, exactly like the first group of novices, and assessed them on day one. We then got them in the lab across a further few days of practice, and then on day 5, reassessed them again. You'll be relieved to see that their technical skill improved significantly. That's unsurprising, and other studies had shown that. That wasn't so interesting. But what was fascinating to us was that as you can see on this same fISOMAP embedding, where we've embedded all the data together, including the data from the previous experiment, you can see that where these subjects finish, which is the green crosses, is closer in their response after training to where the origin of that embedding is, where the majority of the registrar and consultant data set were, suggesting that their brain response as a group has evolved. And similarly, you can map using exactly the same technique, Earth movers distance, to quantify exactly that. And you can see that the light blue bars suggest that you have to work less hard to morph the distribution of novices after training versus before training to the brain response of consultants, and so on. We also looked for within session transient learning improvement. And in fact, we did see that. We didn't see that, unsurprisingly, in the registrar consultant group. This is, again, a well-rehearsed task used in lots of surgical procedures. But we did see an improvement between the second and third knots in the novices in nearly all, if not all, of the performance metrics that you'd like to consider: time, path length, and movements. In the brain, now you're seeing the average response across the prefrontal cortex according to the number of knots. You see the stability of the response in the consultants, and indeed predominantly in the registrars, with very substantial fluctuations in the oxy and deoxyhemoglobin response in between knot 1 and knot 2, which preceded this improvement in technical performance. Again, around that time, we became very interested in the potential for confounders in the fNIRS response, particularly the systemic. And we're of course aware of studies that had been published, for example, looking at the power spectrum of the HBO2 response, showing that heart rate and indeed other physiological signals were present in that data, and also interested by the work by Couture and colleagues using transfer entropy to see what impact the systemic was having on the oxy and deoxyhemoglobin response. Clearly at that time, these were the sorts of devices that were available for monitoring, and they were going to be really quite troublesome in terms of being able to be used in conjunction with technical skills experiments. We then went on, much like Harsimrat has described, in this particular example, not using stimulation to augment anything, just simply looking in a more complex skill, what happens if you train somebody over time down towards the expert proficiency line. Because at that level, as you'll see from the video, it can be quite difficult to determine who is the expert and who, if you like, is the trained novice. And yet this is the benchmark at which most surgeons, the FLS benchmark, where surgeons are, if you like, graduating this laparoscopic task, are deemed to be safe to go out and perform it independently. And we were certainly curious at that time to understand, well, at the point of reaching proficiency, is there a difference in the cognitive burden, if you will, the amount of response at the prefrontal cortex, at the level of the prefrontal cortex? So Kunal Shetty, the PhD student at the time, clinical surgeon in training, ran this experiment where he essentially set up a laparoscopic suturing paradigm. So that's keyhole suturing for those that aren't surgical. Again, using the ETG 4000. We broke the task down, as I'll explain to you in a second, because it's quite a complex task. We evaluated the performance based on the fundamentals of laparoscopic surgery, and we evaluated cognitive burden using modified NASA TLX. And at that point, we were able to identify devices that could be used to evaluate heart rate. So we used the Zephyr bioharness device. In terms of how we broke this task down, we essentially broke it down into 3 components. Needle drive insertion, so that's just inserting the needle across the rent here. The first double throw of a surgical reef knot, and then followed by rest, and then a single throw to complete the knot, followed by rest. So a typical sort of block design fNIRS experiment, but phased to respect the complexity of that task. You can see that we had a substantial number of experts, trainees, and medical students, and we ran a cross-sectional study as shown in A. Again, block design experiment, exactly as I've described, with 3 repetitions of these trials. We then recruited, much like the prior experiment, another group of medical students to undergo a longitudinal learning protocol where they came in for practice and fNIRS assessments and just practice in blue. So quite a number of fNIRS experiments there for those that have done a lot of fNIRS work, a particularly large data set. And then we tracked them and measured their progress to the FLS performance proficiency line. And as you can see in the cross-sectional experiment here, novices perform significantly worse than trainees, who perform significantly worse than experts. So that wasn't something that we were not expecting to see, but it was very nice to see it transpire in the data. It means that the experiment, from a behavioural point of view, really separated out these groups, unlike the previous simple task that I'd shown you, where there was no difference between the trainees and the experts. In the longitudinal experiment, there was significant improvement up to the final session, and no improvement after a gap in retention, suggesting something had been learned. This is a slightly complex slide in terms of I appreciate the fact there's a lot of curves on here, but I'll lead you through it. So in the cross-sectional study, what I'm showing you is a typical fNIRS channel with the novice response in bold and the more senior subjects shown in dotted and hash lines, oxy in red, deoxy in blue. And you can make out, certainly in the single throw knots, that the novice response is more pronounced than the experts. Similarly, in the longitudinal experiment, now the lines refer to the mid-final retention and initial session and so on. And it's much harder to see any real difference in that pattern longitudinally, I would position it to you. And when you actually then go and look at the data statistically, what we see is exactly that on the cross-sectional side, substantial increase in the PFC response, novices relative to trainees and experts, and an increase in the response from trainees to experts. And now we're seeing that difference, if you like, between the different experience grades. But what was most fascinating was, despite the prediction that we would see attenuation in the prefrontal response in the subjects that had undergone repeated learning and training, much like we had seen in the open surgical knot tying experiment, that was not seen in this experiment. In other words, as you can see, from initial to mid to final to retention, the average response is not really changing hugely. And in fact, there was no significant difference longitudinally over time in any of the individual laparoscopic suturing subtasks. And what that really suggests is, even though the subject has performed really well, you saw that they had got to a proficiency benchmark, even at the time of proficiency and retention, where something has been learnt in this complex task, there's still a long way to go to attenuate those prefrontal resources to get them down to the level that we see in experts. And that may have implication for cognitive load and resources in the OR when you are in that very early graduation phase. So if I were to take a pause and summarize what we've seen here, as I said, in the basic open surgical knot tying task, we didn't really see these differences between trainees and experts, big differences between the novices, with quite a high response in the novice subjects reasonably early, suggesting you can get a cognitive plan after relatively limited exposure, and that you attenuate that response with training. One of my colleagues had shown for really complex and very novel tasks like notes, where there's no such thing as an expert as such, and that, well, there certainly wasn't at that time, you see quite a lot of prefrontal response even in the expert subjects. Oachida had taken laparoscopic suturing, and so did we, as you've just seen from the studies by Kunal, showing, again, pretty much as we had seen, that actually the trainees are still really experiencing quite a lot of PFC, or displaying quite a lot of PFC response, which suggests that there is a much, shifted and slower attenuation response for more complex tasks. With respect to using fNIRS in a way that would allow us to compare between training regimens, we explored this with the work that Dave James had done, looking at motor skill stabilization using a robotic approach. Here, what we're trying to do is keep this stylus on a beating heart phantom on the point to be ablated. And you can learn that either in a freehand approach, or as you can see on the screen, using a gaze contingent approach, which applies a force that's proportional to the distance from the stylus to the intended target. So that's in the gaze assisted approach. And again, Dave James took multiple subjects and delivered a learning protocol, either freehand in the control setting or using gaze contingent motor channeling. What we observed was an improvement in the performance longitudinally. Gaze contingent subjects started with a worse performance and improved subsequently, to the point where they then worked significantly better than the control once they'd overcome that learning curve. In terms of the prefrontal response, with pattern A being the oxy increase and deoxy decrease, we see in the GCMC group not so much prefrontal response, and by the end a magnification of the response in the parietal lobe, which is an area that is associated with visuospatial tasks. We then, I think Harsimrat also alluded to this concept of neural efficiency, and we were very interested to look at the functional communication between different areas, on the hypothesis that we would anticipate that as you learn and train to become more efficient, that your brain then, what one would hypothesize, would become more small world, as Harsimrat described, essentially having this local connectedness with a few long-range connections to reach other areas. How do we do that? Well, we use graph theory connectivity analysis. So we essentially correlated the response between a given channel and every other channel to form this association matrix, which then gets pruned, and there's no perfect way necessarily to prune the matrix, but you can do that on the strength of the R value or the strength of the P value, if you like, and then you graph your final, essentially your final connectome. We did exactly that, comparing the initial to mid to final in the GCMC and control group, graphing the functional connections, as you can see on the screen, and immediately you see some differences between the gaze contingent and the control group. You can then conveniently apply graph econometrics. Once you have the final graph, you can then interrogate that for its economy, cost, efficiency. And we found that the GCMC group largely had more economic network, lower costs, and were indeed more small world. Of course, we don't know for sure, but we like to think that that suggests greater efficiency of frontoparietal communication. We know that, and certainly at the time I did this study, we certainly were dealing with a situation where surgeons were still working extremely long hours. Of course, medical practice is a 24/7 business, and sometimes you would need to operate in the evening or certainly in the night. We know that from other work that had been done, that fatigue leads to more medication errors, greater lapses in attention, poor psychomotor vigilance. And so we sought to evaluate this actually through the night shift as it developed. The argument at the time was that there were a lot of studies being done comparing fresh surgeons to after a night shift. And that's primarily, of course, for the convenience of doing that experiment, primarily for the experimenter, because you don't have to be up there through the night doing those measurements. So there were very few measurements, as you can see here, as we had done, taking the subjects from 10 o'clock, midnight, 2 in the morning, 4 in the morning, 6 in the morning, and 8 the next morning, and running serial fNIRS measurements on a cognitive task, in this case, a simple mathematical brain trainer, as a surrogate for a decision-making task, a medical decision-making task, because there wasn't a well-validated one at that time, and serial evaluation of technical performance. This graph summarizes how subjects felt through the night. You won't be surprised to see that on this Epworth sleepiness scale, this introspective fatigue score, through the night, they're becoming more fatigued, to the point where even at 2 in the morning, they're reaching pathological levels of fatigue. Their technical performance actually didn't really deteriorate. It improved a little bit between 10 and midnight, which is akin to a warm-up effect, which has been seen in lots of other studies. But in essence, it didn't deteriorate, nor did their cognitive performance. But this was pretty basic mental arithmetic. This plot was really striking to me, and I think if anyone's new to fNIRS, I think it does tell you that from the PFC response, the prefrontal response, you often get several orders of magnitude greater response if you do a cognitive task than if you do a well-rehearsed technical task. You can sort of see the magnitude of the differences in the oxy and deoxy response, cognitive versus well-rehearsed technical task. But that hid some interesting findings within the data as we look more closely, as illustrated on these topograms of the oxyhemoglobin and total hemoglobin response on the left and right of the screen, for the technical at the top, and arithmetic task. Particularly on the arithmetic task, we saw significant difference at about 6 in the morning, at the time where they're reaching pathological levels of fatigue, versus the 10 o'clock the night before. What this really think was telling us is, actually, you need to invest more response, more response at the level of executive control, if you will, to achieve or to keep your performance at a relative stability. It does open interesting questions about if this is indeed a compensation mechanism, fatigue, to keep your performance at a certain level. What happens when that compensation mechanism fails? Of course, this study didn't expose that, but it does open very interesting questions about that. And finally, looking at intraoperative stress, the best example I can give you in surgery, I suspect, is bleeding. Bleeding is very visceral, as you see it on the screen. You have a tendency to go, oh my God, that needs to be controlled, pretty swiftly. And you can sort of see a difference between the way perhaps the surgeon on the right and the way the surgeon on the left is perhaps dealing with that degree of bleeding. And it led us to this interesting question of what's happening in the surgeon around these times, and can we tease out some differences in the way surgeons can cope under pressure? Our team were very interested by work that had been done outside of our lab, albeit in non-surgical studies, that suggest that as you increase the cognitive work, you increase the prefrontal response, but you can only go up to a certain point, and then there's this sort of tipping point, perhaps, where things start to go belly up, and you essentially can't compensate any longer. And we were very interested in interrogating this in surgery. And so, as I think Harsimrat started his presentation with the next stage of this experiment, so I'll tell you about the first phase of the experiment. We essentially recruited subjects, this was a study done by Hemal Modi, to perform this laparoscopic suturing experiment, as you can see here. But unwarned at various points in the experiment, they were told that they had to do this under a time pressure. They had only two minutes. Now, of course, that's not the same as seeing bleeding, but we know that it recreates that same feeling of needing to get on with it and get the task done. So it was really designed to recreate that sense of temporal urgency. Exactly as Harsimrat has presented, we evaluated performance objectively using the progression score. How far did they get through the task? Leak. We used a tensiometer to evaluate the knot tensile strength on the basis that if that deteriorates, you've got less strong knots. there's a greater chance that the hole might leak blood internally if it were a real case. And we measured the degree of distance between the actual entry point and a pre-marked point. We were able to recruit trainees, as it transpires, of different grades. They were all trainees, surgeons in training, but they were all different grades in their training. So some junior, some senior, and so on. What we observed was actually the junior and intermediate trainees had a significant increase in the surge TLX. They really felt that the task put them under a lot of pressure, i.e. the temporal urgency task relative to the self-paced task. Task progression suffered significantly, and error scores increased, and not tensile strength in both groups, you can see, really substantially plummeted. And in the senior group, well, the error scores, sorry, the error score went up, but that was the only marker that you could glean from the technical performance that they were under pressure. With respect to the prefrontal responses, what we're showing you here is the prefrontal response with significant channels highlighted. You see the junior, intermediate, senior trainees, the self-paced condition, and the time pressure condition. And hopefully what you can see is it doesn't matter what grade you are, you see this slight decline, and substantial decline as it transpires in the junior trainee under pressure. You also see the same in the senior trainee, particularly in this right PFC area. But there is a general tendency for the senior trainee to maintain that degree of activation under time pressure. And as you get more junior, you seem to have an inability to maintain attention and concentration as indexed by prefrontal responses. When we ran random effect modeling, as I said, to account for the subject level variance, in the junior trainees, condition was a significant, essentially a significant factor, whereas condition, i.e. temporal stress or self-paced, was not a significant factor in the senior trainees. You can see when we compare now highlighted red, the temporal demand oxyhemoglobin was greater than the self-paced condition. Blue, the temporal demand oxyhemoglobin was less. You see, in terms of significance, which are these black circles, you see that really the only significant channels are the ones depicting a decline, a gradient towards a lower oxyhemoglobin response in temporal demand. Harsimrat already presented this. I think it's a really interesting slide. It demonstrates when we basically throw the whole thing up in the air and say forget what we understand about experience. We see here that actually you've got some senior trainees whose performance from the self-paced in these squares to the time pressure condition, the circle, are plummeting quite substantially. They're very sensitive to stress. And similarly, other trainees that perhaps are more junior, where it seems to affect them less. We're then able to divide the cohort into Q1, those that are less sensitive to stress, and Q4, those that are most sensitive to stress. And you think, well, do we really need the brain? Could we use some other measure to tease out who the copers and the chokers are? Perhaps it's just shown in the heart rate. Well, we didn't see any significant difference in the heart rate. It wasn't like the Q4 residents. Their heart rate, their systemic was much greater. What about surge TLX? Can you use that? Perhaps those in Q4 that struggled, they felt it more. Well, there was a significant increase in both groups under pressure, so you can't really use that either. What was really fascinating was when we mapped out, this is Harsimrat, Hemel and myself, the temporal time courses of the hemodynamic response of those that were in the Q4 versus the Q1, the copers. You can see in the self-paced, and particularly in the time pressure condition, responses that look like typical hemodynamic time course curves, a rise in oxy, a drop in deoxy. And actually, if anything, there were many examples where in the Q4 residents of inverted hemodynamic responses, rises in rises in deoxyhemoglobin, as you can see here, and a drop in oxygenated hemoglobin. So if you like, an inverted pattern, which we label deactivation. You're seeing exactly the same now in the delta hemodynamic, the delta HB, right? So that's that task minus baseline. When you map that out in the self-paced condition, this row for every channel, time pressure condition, this plot for every channel, you see the Q4 residents, those that are more sensitive to stress. You see this in many prefrontal channels, the tendency to a decrease in oxygenated hemoglobin or deactivation. Sorry. And again, showing you exactly the same, really, in this graphic. You're seeing where the activations are greatest in orange. Oxyhemoglobin heading in essentially the opposite direction, so a decline in oxy response, primarily in the Q4 residents in a number of channels in both the right and left dorsolateral prefrontal cortex. So where might some of this be heading? You've already heard from Harsimrat about essentially augmenting the response. Of course, if we can use the brain, or if we're getting studies that are telling us that the brain may herald a certain cognitive state of the operator, then it does beg the question, can we move to a set of circumstances in the future where we can detect some of those things more seamlessly and then use that information to do something intelligent in the environment. Exactly as Harsimrat says, in terms of his acknowledgements, exactly the same. Pay a huge amount of gratitude to our funders, our colleagues in our lab, particularly to Harsimrat, Hemel, Kunal, Felipe, and our leaders, Professor Dazi and Professor Yang.
Thank you so much for taking us on this fascinating journey on understanding and enhancing surgical performances. I, for one, am very impressed to see how comprehensively you are addressing this subject. So, congratulations on that. Also, the PFC responses in the knot tying experiments among novices and experts, it reminds me of studies in professional athletes as compared to amateurs, where the pros depict a much more refined employment of the motor cortex. So it's really nice to see some cross-domain validation there.
Yes, and there are many studies, outside of the field of medicine, as you quite rightly described, that really, I mean, in many ways, it makes sense to a certain degree, not only that we're finding the same things that have been found elsewhere, but that was a really sensible starting point for us, was to try and see if we demonstrate these kind of patterns in surgeons, because it was a pretty well-grounded hypothesis at that point. Of course, we're aware of something that, and in fact, some of our own data attest to the same, but it's not just about the prefrontal cortex, of course. We have got work that demonstrates SMA, M1, the way that those areas are changing, much like that kind of redistribution, reorganization slide I presented, where you see more senior subjects are starting to drive off more M1 responses when it comes to really just isolate a drill, isolate a motor task. Very limited at that point cognitive overlay, or cognitive making overlay, if you like. But when you start getting, as Harsimrat represented, I think in a few of his first slides, where we've moved on to evaluating both the motor and the cognitive, of course, then it's more tricky because you've got cognitive overlay on top.
Yeah, fascinating. Okay, we do have some questions at this point. I would also invite Harsimrat to join back if he can. We actually have a lot of questions, but given the time constraint, I will try to address the most common ones, or let's say applicable to a more general audience. And first one will be for Harsimrat. What considerations do one need to think about when doing stimulation and fNIRs? Can there be crosstalk between fNIRs and TDCS?
Well, it's a really good question. I mean, we took a lot of time designing these studies, and it depends on how you design your montage, really. But in terms of whether or not you're looking at the channels on the electrodes, across the electrodes, you know, for example. And sometimes it depends on the site of stimulation as well, where you're, so some people do not use the prefrontal cortex montage as we use. They might use some other and record from another part of the brain, for example. And there are some evidences of people doing that. And most people don't do it at the same time.
Right.
So they do a pre, then stimulate the brain, and then record a post. So there are several ways to do this study, but we were really interested in an online during stimulation scenario and looking at the hemodynamic changes. So yeah, I mean, fNIRS more than crosstalk with the NIRS port 2 that we used. I think it was a case of keeping it stable and not having the channels lose connection because of two large parts
Of course.
pads on the brain, and also the short separation channels I think are a revelation in this regard. For example, the redness of the screen, which might give you an extracerebral blood volume change, can be taken out with the short separation channel. So yes, it's an answer which might not give you everything, but you really have to kind of collaborate with people who know what they're doing really,
of course,
more than anything else, because it depends on your study design, it depends on your experimental setup, and there are ways to avoid crosstalk.
Yeah, of course. So yeah, it is a real estate question, I think, because the modalities they don't interact with each other. One is electrical in nature, the other is optical in nature, so they work quite well in that respect. Right. I would also like to include Daniel in between, so I will switch between you two. For Daniel, the first question is, yeah, it's about the journey. You explained the task and their complexity, as you have mentioned, evolved in the previous years from apple peeling to surgical skills. How do you think recent technological advances will further push the field?
I mean, I think that's a really good question. And I think, you know, we've always, I mean, it's been a long journey, as you know, up to this point. But clearly, I guess in the grand scheme of the journey, we're only scratched the surface. You know, we're probably just, you know, I don't know, we're probably just a fetus, really, in the grand scheme of the journey. I guess the journey for me is always to the operating room. But we've deliberately not done that up to this point, because I think there's a very real danger of going into the operating room and not being able to make sense of anything that you're doing, unless you actually have a clear understanding of some of the real, you know, what are the kind of responses that you expect to get from these various tasks. So I think there's the kind of level of understanding that we need to internally, and perhaps as a community, to get a better sense for when is the right time to go into the OR and actually get these measurements live. And I think in terms of the technological advance, as I think, you know, you've seen, I know we presented it in the slight reverse order, but clearly we've gone from a system that's, you know, a big weighty system to the NIRx system that is more mobile, you know, it's going to be, you know, easier to take into the OR. But one would hope that as the technology, again, further improves, can we get even more discrete? I mean, I would love to have something that just sits under the surgical hat, for example. But I think there's engineering developments that need to happen in order that would wirelessly send signals reliably to wherever it is, whether it be, you know, on the fly, getting that information out on the fly, and interpreting it so we can actually do something with it. So I think at some point, shift from measuring to actually using the data.
Absolutely, yeah. And I think the recent trends in explaining the covariates, considering the covariates, the heart rate, the respiration, for example, the trainees maybe, they are nervous or under more stress. So adding those extra physiological parameters into along with fNIRS, I think that could really.
Agreed, and regressing out some of those things from the response, as Harsimrat alluded to. I mean, again, NIRx, channel separation, enabling us to do that, right? So, whereas before we were like, well, what is the impact? Now we can at least use that separation to kind of get a better sense for what is that extra component.
Exactly. Yeah. Okay. For Harsimrat, you talked about augmentation. Could this augmented performance be maintained over time, or is it just an acute effect?
Yeah, so it's a $1 million question. I mean, it is as Dan's explained. In his journey, he's moved on from a chunky ETG to a NIRx, and then from there on to do a TDCS, and so we are at a point where we see a clear improvement in performance, and whether or not it can be retained needs a bigger study, which we are embarking on. So we have already plans and ethical approval and some new equipment that we're going to use for doing this. So yeah, watch the space, I'd say.
Looking forward to that. Looking forward to reading those Nature papers.
Oh.
Okay. Right, then I will move to Daniel again. And this is a question I have been interested in for a long time. It's about the paradoxical decrease in PFC activation in the poor performance or choker, so to say. Does this reflect recruitment of other cortical constructs?
Yeah, I mean, so in other words, almost like the steal phenomenon, like you're stealing blood away. Yeah, and
vascular steal.
Yeah, we put forward a number of potential hypotheses, including that steal phenomenon. But I think the reality is we just don't know. We don't know, and it is really fascinating because the first time we saw it, we thought, no, this can't be. I looked at it and thought, this is too clear as night and day as being, and then lo and behold, actually, this was apparent in multiple subjects. It says this was beyond one or two. It was multiple subjects in that cohort. So there's something very real. What it is, we can't. And we went back at the time. I think Harsimrat will attest to that. To ask the kind of neurophysiology question. What at the brain level? What mechanism at brain level explains this phenomenon of the hemodynamic? And I don't think we've had hasn't really been, excuse me, much in the way of a model that could explain it.
Yeah, I think what you discuss in the end, the connectivity measures, I guess, could shed some light on that. Just looking at all the areas simultaneously and how they interact. Okay.
Yeah, the multimodal platform, whether that be with E or something like that, might give us some insights. Yeah.
Yeah. Okay. Right. Then I think the last two questions, also for Daniel, do you suspect a transfer of acquired skills to be reflected in another cortical region beyond the PFC?
Yeah, absolutely. And I think I think I answered that in part previously, that with wider coverage, I think you would see that distribution. Excuse me. I think some colleagues are now publishing on exactly that point, that they're using the response from motor areas to generate an even more elaborate kind of understanding of how things shift. And as pretty much like Harsimrat presented in terms of our classify using connectivity, there are similar studies looking at just the oxyhemoglobin response or deoxyhemoglobin response, but they are looking at that much broader area of the cortex. And so I think we already know some of the answers, and even indeed our our own studies, I'm now thinking of the ones done by Kunal Shetty, primarily the laparoscopic training studies. They show something very similar. We published on the PFC ones, but actually this was much wider coverage, and we saw changes in FA, M1 that would reflect in other learning studies.
Fascinating. Okay, I think we could stop here. We have a bunch of other questions, but we can answer those offline. And we cannot thank you enough, Dr. Harsimrat Singh, Dr. Daniel Leff. I know you are very busy guys. I could see from the number of publications you produce every year. So thanks a lot from the whole NIRx team. I think our users enjoyed it very much.
Thank you so much.
Thanks for the invite.
Great.
Our pleasure. Thank you.